Welcome back, everyone, to part 4 of our 15-part Interventional Radiology Coding Masterclass. I am so pumped to have you here today. If you've been with us so far, you know we've been laying down a super solid foundation of medical coding knowledge. Well, today we're literally diving into the vessels themselves. We're going to master the fundamental concepts of diagnostic angiography and catheter placement. This is exactly where the clinical action translates directly into the codes we report. So let's get focused and jump right in.
First off, you guys are crushing it. Interventional radiology can feel incredibly dense, but you are cracking the code. To really get today's topic, I want you to picture the human vascular system as this massive, complex, pitch-black highway. Now, if a doctor wants to travel down this highway, say to find a roadblock or drop off a repair crew, they can't just drive blind, right? They need two things: a reliable vehicle and a really powerful set of headlights to see where they're going. Keep that analogy in your back pocket as we go.
Here's our roadmap for this explainer. We'll cover the angiography technique, the catheter placement process, and their clinical importance. Then, we'll dive into an essential coder's note and wrap it all up with a summary and a teaser for Part 5.
Section 1, the angiography technique, or illuminating the roadmap.
So what actually is angiography? Basically, it's a real-time imaging technique that lets physicians see right inside the blood vessels. We're talking about the vascular lumen, which is totally invisible to the naked eye. To pull this off, they inject a contrast dye. See, blood vessels don't naturally pop on a standard X-ray, so this contrast dye acts like a literal flare in the dark. It completely highlights the shape, the size, and the pathway of those vessels. It is absolutely crucial for identifying vascular conditions and guiding any treatments that follow.
The way they do this without making huge surgical incisions is honestly wild. The physician performs a controlled injection of radio-opaque contrast dye right into the vascular system. And as that dye flows, boom, the internal structures light up beautifully. But, dye alone isn't enough. It has to be paired with real-time imaging guidance, stuff like X-ray fluoroscopy, ultrasound, CT, or MRI. Put the dye and the imaging together, and you have the absolute foundation for minimally invasive diagnostic procedures.
When you're actually in the procedural suite, this imaging acts as a dynamic, live feed of the internal anatomy. We're not talking about a static snapshot taken after the fact. It's a living, breathing roadmap. This immediate feedback is exactly what lets the interventional radiologist maneuver safely through that vascular highway using just tiny portals, rather than large open surgical cuts.
Section 2, the catheter placement process, or as we like to call it, navigating the vehicle.
Okay, so our headlights are on, but how does a physician actually get inside the vessel? It's a very precise, step-by-step, percutaneous approach, meaning through the skin. You'll see this a lot in your operative reports. They might establish entry via the common femoral artery in the groin. Once they have that initial access, they carefully thread this incredibly thin, flexible guide wire into the vessel. Finally, a specialized thin tube, the catheter, is advanced right over that wire and into the vascular system. It's kind of like the guide wire is the train track and the catheter is the train, just following the track deep into the body to map things out or deliver therapy.
These specialized, super flexible, thin tubes are the ultimate tools of the trade. They come in all sorts of shapes and sizes, usually measured in what we call French, and they're specifically designed to curve and twist through the crazy branching anatomy of our arteries and veins. Literally, without these advanced tools, minimally invasive vascular access wouldn't even be a thing.
Section 3, clinical importance in practice. Let's look at the why of vascular interventional radiology. So we know the how, but let's talk about the why. It really boils down to a two-part approach: diagnostic and therapeutic. Diagnostic is all about imaging and identifying. Is there a disease? Is there a blockage? Are the vessels narrowed, which we call stenosis? Catheterization and angiography answer those exact questions. Then, once they spot the problem, we move to therapeutic. This is treating or managing the condition, like doing an angioplasty to widen a narrowed vessel or placing a stent. The huge takeaway here: diagnostic catheterization is the vital, mandatory foundation before any therapeutic cardiovascular intervention can happen.
Because when you're dealing with these incredibly complex, branching vascular networks, mapping the terrain first is non-negotiable. A physician just can't safely deploy a stent or do a life-saving embolization with a crystal-clear picture of the specific vascular terrain they're in. It's like trying to navigate a sprawling, dense city without GPS. You just wouldn't do it. This imaging prevents those dangerous blind spots.
Section 4, essential coder's note. This is where we bridge the clinical reality directly over to the coding.
All right, this is what you've been waiting for.
I want you to grab a pen and write this formula down. Catheter positioning plus dye injection equals the foundation of selective versus non-selective coding. In vascular procedural coding, understanding the physical anatomical journey of that catheter is your primary building block. You aren't just coding a surgery, you're tracking a journey. The exact combination of where the catheter is placed and where the dye is injected dictates the codes you're going to select.
Let's break down how this actually looks when you're staring at an operative report. First, you have to find the specific anatomical access point. Did they go in through the right femoral artery? Okay, great. Next, track the catheter's journey as it advances. Maybe it goes from the abdominal aorta into the common iliac artery and finally drops down into the superficial femoral artery. Here is your golden rule, folks. The final anatomical placement of the catheter is what dictates your code. If its final destination is the left superficial femoral artery, you code for that final placement. And remember, that final placement code inherently bundles in all the lesser first-order selections made along the way. So you don't code every single pit stop, just the final destination.
Section 5, Summary and Part 5 Teaser. Let's wrap up and look ahead.
We've covered some massive ground today, so let's do a rapid-fire recap of your 3 biggest takeaways. Number 1, angiography is your headlights. It uses contrast dye and real-time imaging to visualize the vessels. Number 2, catheters are your vehicle. Thin tubes introduced percutaneously over a guide wire to navigate the body. And number 3, the coding golden rule. Final anatomical catheter placement is the main driver for accurate selective vascular coding.
So you get the vehicle, you get the headlights. But what actually happens when we start driving into completely different neighborhoods? In Part 5, we're introducing you to the vascular families. We'll dive into the arterial system, the venous system, and the incredible lymphatic system. It is absolutely going to take your coding accuracy to a whole new level.
You've now got the foundational knowledge of how and why we access the vessels, but I want to leave you with this. If the catheter crosses into a brand new, highly complex vascular territory, how will your coding logic need to adapt? We're going to crack that exact puzzle next time. I am so proud of the work you're putting into mastering this complex specialty. Thank you for watching, and keep learning with Decode Healthcare with Harshel.